All right. Well, hello, everyone. We're going to go ahead and get started. Good afternoon or good evening to everybody who's with us today for another session of Virtual Global Spine Conference. We are absolutely thrilled to have a good friend and colleague with us today, Dr. Camilo Molina, who is an assistant professor of neurosurgery and orthopedic surgery at WashU in St. Louis. For those of you who don't know Dr. Molina, he, of course, is I would say, relatively younger surgeons at WashU, but nevertheless has already made a huge impact in our field in terms of basically innovative techniques, technologies, very already very well established and really an expert in enabling technologies and virtual reality. And he's our guest today speaking on fixed spinal deformity. So Camilo, welcome to Virtual Spine, and we're really happy you can be with us. Thank you for being here.
Thank you for the kind introduction, Ali. So I guess in the interest of time, I'll go ahead and get started. Really the objective of this talk is to maybe walk the audience through how I think about these cases, how I approach them, from A to Z. No relevant disclosures really in this talk, except that the majority of the instrumentation, I guess, listed here will be from the Pew, but nothing else that's relevant. So let's get started really with presenting a case. This is a 68-year-old female. She presents to my clinic with severe back pain and leg pain. She's had a multitude of thoracolumbar spine fusions. She's essentially started with a L5-1 fusion and posteriorly, and was subsequently extended up to L3 and then extended up to T9 or T10, I forget, and then a level above that after she PJK'd. As you can see, each time she's essentially been made flatter and flatter progressively more and more. And then her surgeon told her that there's nothing else that could be done. And so they gave her an intrathecal, I believe, morphine pump, and so subsequently upped the dose until she was maxed out on the dose. And she was still miserable. And so they referred her to university. In terms of her past medical history, standard things for somebody in this age group: hypertension, well-controlled type 2 diabetes, and she thankfully is a non-smoker. She did have a prior spinal cord stimulator, but that was removed in exchange for the pain pump. She's grossly neurologically intact, with the exception of, kind of breakaway giveness throughout her bilateral lower extremities and all her muscle groups. She does have a chronic left-sided subtle foot drop as well. And when we look at, some of the basic PROMs, ODI, she's in that maximal category where she's at 70. She's essentially completely crippled by this. She's walker dependent, unable to really walk for more than 1 to 2 minutes without severe pain and disability, and is essentially, recliner ridden. She doesn't want to participate with any of her activities of daily living. And so when I see somebody like this, the surgical indications perhaps are not that murky. It's clear that this person has a severe iatrogenic fixed deformity. She has a solid rigid fusion, and she's standing with multiple compensatory mechanisms. She's got hyperextension of her upper thoracic spine, hyperextension of her cervical spine, all in the effort of trying to maintain a horizontal gaze. And she's starting to flex her knees already. One thing that you'll notice is her pelvic tilt is actually not that elevated, and it's because she has a low pelvic incidence, as I'll show you. And people with low pelvic incidences have very poor pelvic retroversion compensatory abilities. And then, notice that I don't necessarily talk about her age as a contraindication or indication, and particularly towards my surgical goals, because I think frailty is more important. I've seen a lot of 40 and 50-year-olds in my 50-year-olds in my clinic that looked at quite frail, not robust at all. I do not think that they could tolerate a big, large surgical correction. But there are, people in their 60s, 70s, late 70s who are quite robust, healthy, good nutrition, good bone, who I think would tolerate from a physiologic and biomechanical deformity correction. So I'm more of a believer in biological age and frailty rather than chronological age, as I figure out which of these patients are surgical candidates and how aggressive of a correction I want to perform for these patients. Incredibly important is their mental health, their expectations of what the surgery is going to grant them, what the surgery is going to be like, and what type of support they have. The surgery is not over when they get off the table. There's an somewhat extended perioperative, postoperative course. Then they 90% of the time go to rehab after that. And even after they get discharged from rehab and they're sent home, they still require quite a bit of help to get around, to do their activities of daily living. If they have an extension to the upper thoracic spine, they're going to need to learn to adapt to do things as simple as personal hygiene, picking things up. Their mobility for the first couple of weeks to months is significantly limited. So it's not something that you can do to someone who doesn't have any other potential caretakers that can help them get through the next 6 months of their life. And then the interesting stuff, the imaging. For every single one of these patients, I get 36-inch AP and lateral standing films. We have EOS at our hospital, which I really love, because not only do you see the entire spine, but you can see what the hips, what the knees and the ankles are doing, because those are the last compensatory mechanisms that people have when they're completely failing from a sagittal balance standpoint. I like to get flexion, extension, lumbar films when I have particularly patients who may not have a fixed deformity or may have a pseudoarthrosis, and maybe they had a posterior lateral fusion attempted, but it didn't take, and their discs are open in the front, and they have vacuum discs. So some of those people are, you don't necessarily have to think about doing a 3-column osteotomy. You may just need to take down some of that pseudoarthros, the partial fusion bone, and you can remobilize them without doing something as morbid as a 3-column osteotomy. Whenever there's a coronal scoliosis, I get bending films. I really like supine films, again, for people who I don't think are rigid, because it tells you, where the spine is going to be when you lay them on the table. And it, sometimes it looks a lot better than when they're standing, I would say. And in fact, most of the time it does when they don't have a rigid deformity. And it may lead you away from doing a, more aggressive surgical plan than you need to, because you find that on those supine films, they actually realign themselves quite nicely. And then, of course, the CT is of utmost importance. Similar to the supine films, you can see positional alignment changes to the spine. You get a sense of the quality of the bone, where things are fused, where they're not fused, presence of vacuum discs, the integrity of the prior instrumentation, and you get a sense of critical, not just osseous, but neurovascular and visceral anatomy as well. It goes without saying that MRIs are also important, particularly if the patient has any neurological symptoms that are residual from their prior surgery or new symptoms. If you don't have access to metal suppression MRI protocols, CT myelogram is also incredibly helpful. And then a DEXA scan. I really don't take these cases on without knowing what type of bone quality a patient has. You can have the grandest surgical plan, but if the bone is not healthy enough to hold the screws and the instrumentation, everything that you do is likely going to fall apart. And then in terms of measurements, I'm going to walk through the things that I measure in every single one of these cases. I would venture to say that most people on this audience are familiar with the basics of, the pelvic parameters, sacral slope, the pelvic tilt, and the pelvic incidence. The pelvic incidence being a line that's drawn 90 degrees from the sacral end plate and down to a line that's 90 degrees from the sacral end plate and down. It tells you the shape of the pelvis, and it's a fixed parameter in adulthood. And it essentially tells us where that patient, where their pelvis wants to be and how much lordosis they need to compensate for the angulation or inclination of their pelvis. The pelvic tilt, variable. It can go up or down. It's measured with a line drawn from the mid-sacral end plate, and the angle that line forms with a line that's vertical to the image or to the ground. Why that's important is because it tells you how much the patient is anteverting or retroverting their pelvis. Most people are not going to antevert their pelvis unless they have too much lumbar lordosis or not enough thoracic kyphosis. So they need to actually bring their pelvis forward to not have their head behind their pelvis. But what we're going to predominantly find in our patients with adult spinal deformity, particularly fixed deformities, that they have elevated pelvic retroversion. And pelvic tilt is not just a fixed number in space. That you really need to think about pelvic tilt in the context of what their pelvic incidence is. Because if you remember, the basics of this is that pelvic incidence is equal to pelvic tilt plus sacral slope. So a patient theoretically cannot retrovert their pelvis more than what their pelvic incidence is, because you cannot make your sacral slope less than 0. That would be, more than parallel to the ground. So you find that people with low pelvic incidences actually have very poor pelvic tilt compensatory retroversion ability versus people with high pelvic tilts, say a pelvic incidence of 75 or 80. You may find those people with a pelvic tilt of 25 to 30 degrees who are relatively asymptomatic versus a person with a pelvic incidence like this lady of 39. If you gave her a pelvic tilt of 30 degrees, she's absolutely miserable. So these values cannot just be taken in isolation. They really need to be thought of in the context of the entire pelvic parameters. And then, moving on, SVA, everybody's familiar with this. It's a plumb line drawn from C7 and straight down, and then a measured to the distance of the posterior superior end plate of S1. SVA, I think, is an important parameter, but I like to look at it more as a trend, not as an absolute value, because if a patient retroverts their pelvis, they can make their SVA look significantly better, even though they're sagittally poorly malaligned. And so I look at SVA more to see where we started and where we finished, rather than an absolute value. And then, of course, we look at the lumbar lordosis, L1 to S1, and we think about that PI-LL mismatch. Now, I'll tell you that I don't necessarily follow this PI-LL mismatch plus or minus 10 degrees, and I'll explain in a little bit why. But nonetheless, I do like to see what that lordosis is and how far they are off from their pelvic incidence. In this case, the patient is about 21 degrees off. And then this is the T1 pelvic angle. This is probably my favorite angle to measure, because this angle removes pelvic retroversion as a compensatory number and tells you essentially where in space the top of their thoracic spine is in relation to their pelvis. So this is the T1 pelvic angle. And it's measured from the mid T1 vertebral body to the mid femoral axis, and then to the mid S1 end plate. And regardless of where the patient retroverts their pelvis, this number is going to stay fixed. In general, you read the literature. Most people recommend that this number be less than 14 degrees. And then into the surgical plan, we have it's actually just built into our packs in our hospital. It's not even as sophisticated as SurgiMap, but it does have the ability to plan osteotomies in an ankylosed spine. And why I say ankylosed is because once you plan these osteotomies in the system, it assumes that the part above and below the osteotomy are completely rigid, and it's not going to undergo any type of compensatory bending. And that's important to think about in your mind and compensate for, because especially if it's a low fusion like T10, there is going to be some compensatory kyphosis after that if this patient was hyperextending their thoracic spine prior to getting this image. But nonetheless, these modern pack systems, SurgiMap, or whether this is built into your packs, really allow you to plan where the osteotomy will be, how many degrees you need to close it, what the new lordosis will be. And when you give that patient that certain amount of planned lordosis, you can actually play with what their new pelvic tilt will be, what their new T1 pelvic angle will be, and see if it's where you want that patient to stand in space. And I implore everybody to do this, because you'll find that once you do these kind of more advanced plans, this pelvic incidence plus or minus 10 degrees of L mismatch with age-adjusted variables kind of starts going out the window. You'll see that especially low PI people, need a lot more lordosis than their pelvic incidence to get their head above their pelvis, whereas high PI people need a lot less lordosis than you would expect to get their head above their pelvis. And so what are the goals of surgery in general? This patient is not necessarily coming in with any radiculopathy or neurogenic claudication. What they're really coming in is with severe flat back deformity type symptoms, complete biomechanical decompensation, just severe back pain, muscle fatigue. And so we really just want this patient to be able to stand in a more biomechanically advantageous fashion to get her pain under control, and hopefully not just get her off narcotics, but hopefully get her off this pump. And I didn't really go into this earlier, but all these patients prior to surgery, if they have these intrathecal pain pumps, I have them completely wean it off. Because I'm ultimately trying to get them off narcotics, but B, if they stay on these pumps, the pain control after surgery is going to be tremendously difficult. In general, we obviously want to minimize the levels of surgery, and we want a durable result. And I think the key to getting that durable result is to actually nail the alignment so that the spine and the hardware or the instrumentation are not fighting each other to maintain the patient's position in space. If they're harmonious and they're in a correct alignment, then we're going to find that our constructs have a lot longer durations. And then I'll say briefly, age adjustment targets. I think this is important. It's important to think about that life is a kyphosing event, but this is not an absolute end all be all where this is exactly what you should target, because it doesn't really tell you that much about the patient. And I think it doesn't make a whole lot of sense to say that a 74-year-old can have a pelvic tilt of 25, but next year their SVA can go from 5 to 8 centimeters, and that's okay. Those kind of normalized means categories, I don't think have a lot of true clinical applicability, and a lot of these values don't tell you where they stand with relation to that patient's pelvic incidence. I can tell you that if any 74 or 75-year-old who has a low pelvic incidence of say 40, if they have a pelvic tilt of 28, they're going to be miserable. It doesn't matter that they're 75 or 76 years old. And so in those patients, you really have to think about, are they robust enough to get the correction that they need to, actually be able to stand in space where they need to be. And then the other thing that this really doesn't tell you is what's their thoracic spine doing. So you'll find that some people have, because age is a kyphosing event, they have severe thoracic hyperkyphosis, and you may not necessarily want to go in and correct that thoracic hyperkyphosis, because that may be very prone to instrumentation failure, especially these patients that are osteopenic, where your instrumentation pulls out as you're trying to take that kyphosis out, and it may actually be easier to dial in a lot more lordosis than their pelvic incidence would suggest to balance out the curves of their spine, and again, to get that durable result. I think everybody's familiar with that SRS Schwab classification, so I won't go into that, but I will say that since coming to WashU and spending a lot of time with the orthopedic surgeons here, I've become very ingrained and not necessarily thinking about those, Schwab classifications, but thinking about the spine more in a spectrum. And a lot of this will go into the Roosterly classification. And if you read about the Roosterly classification, you know that he was heavily influenced by Dubois. And Dubois's put out a ton of literature. Everybody's familiar with the cone of economy, etc. But one of my favorite things that Dubois put out is this geometrical proof about the curves of the spine. So he goes into this theorem that you can divide the spine not in anatomical segments, but in functional segments. And what he means by that is that he felt that it was archaic to say that the thoracic kyphosis is from T1 to T12 and lumbar lordosis from L1 to L5, because different people have different inflection points. So you may have lordosis all the way from L5 to T11, or you may have lordosis only from L5 to L3 and then kyphosis above that. So he felt that it was more informative and perhaps a little bit more advanced and insightful to divide the spine in functional segments based on where inflection points occur. So he came up with the kyphotic curve and the lordotic curve. And it was regardless of whether this occurred in the conventional thoracic or lumbar spine. It really just mattered into where the inflection point occurred from kyphosis, from spinal kyphosis to spinal lordosis. And that was the first inflection point. And then he took the kyphotic curve and divided it where at its apex, and took the lordotic curve and divided that at its apex. So then that gave him 4 arches: the lower lordotic arch, the upper lordotic arch, the lower kyphotic arch, and the upper kyphotic arch. And then he goes into these geometrical proofs that the lower lordotic arch is equal to the sacral slope. The upper, and this is really, really important, the upper lordotic arch is equal to the lower kyphotic arch. And this tells you that if you start building, if you flatten out the lower arch and you start building lordosis in your upper arch, you're going to promote a compensatory kyphotic event in your spine and your lower kyphotic arch. And what does that mean? That's a PJK machine. So if that's a non-instrumented segment, it's likely going to PJK. If it is instrumented, that your spine is fighting your instrumentation, and you're potentially precipitating an earlier than expected instrumentation failure of that segment of the spine, because that's not where the spine wants to be. So the key into this is it really led to Roosterly developing his Roosterly curves, as we'll talk about, based on where the inflection points of the functional kyphosis and lordosis are. And B, it tells us what to expect in the spine when we start changing the alignment in certain places. And it tells us maybe we should be shooting for changing the alignment in that lower lordotic arch to match the sacral slope, or the theoretical ideal sacral slope of that patient, that we're guided by knowing what their pelvic incidence is. So, moving on to how this precipitated these Roosterly curves, we know that there's 4 types of Roosterly curves: type 1, type 2, type 3, type 4. And Roosterly originally described these curves based on the sacral slope of the patient in a non-pathologic conformation, meaning the spine had not degenerated yet. Because we're treating degenerative adult spinal deformity, particularly that is fixed and likely iatrogenic, these people no longer have healthy sacral slopes as they would have in their non-pathologic states. So we cannot deduce the shape of their Roosterly curve based on their sacral slope, because they're retroverting their pelvis most of the time and have falsely elevated sacral slopes. So we have to translate these curve categorizations into their pelvic incidence. But before we go into that, just to understand what the basics of these different curve types are, is they're classified basically on 2 things: A, whether it's a low sacral slope or low pelvic incidence, and B, where the transition from kyphosis to lordosis occurs. So in a type 1 Roosterly curve, this is a low sacral slope, or low PI, less than 50 degrees curve, and it has a very early transition point from lordosis to kyphosis. So you can see that the spine is only lordotic up to L3, and around the L3-4 disc space, the spine transitions into a long, broad kyphosis. Then there's a type 2 Roosterly curve, where it's once again a very low sacral slope or low PI, but the transition point occurs at a more natural place between the conventional thoracic to lumbar anatomical transition at the T12L1 disc space. So what that means is that since it's a low PI or a low sacral slope, that lordosis is distributed along more vertebrae, and so you have a much flatter lumbar spine, and subsequently a much flatter thoracic spine. Again, think that in comparison to the type 1 curve, where you concentrate all of that lordosis in just 3 vertebrae, you have a lot more lordosis concentrated from L3 to L5, and then and then you have that inflection point with a very long, broad kyphosis. Even though those 2 patients have the same PI or sacral slope, you can see that where they need lordosis is going to be very different. Then you go into the high sacral slope or high PI patients, type 3 versus type 4. The main difference here is, again, where that transition point or that inflection point occurs. In a type 3 patient, it occurs around the T12L1 display, so the mid T12 vertebral body, versus type 4 that occurs much higher around the T11, T12 disc space. And so it results in a much larger lordotic curve and subsequently a shorter but more pronounced kyphotic thoracic curve. One of my favorite things about thinking of the spine in these Roosterly classifications is that if you start looking at the patients when they come to your clinic, when they're decompensated, you can start seeing them and catching them in the different stages of the degeneration based on what type of curve they are. So, we'll take, for example, a type, let's say a type 3 curve. It starts out balanced when the patient's at a healthy age, and then we start having that, age expected degenerative disc disease with the loss of lumbar lordosis. So this leads to the first stage of degeneration, which is a false type 2 retroverted curve. So what does that mean? Is that what that means is that if you look at it without taking into account the position of the pelvis to the femoral heads, it looks like a balanced spine. But in reality, what it is that due to the loss of lordosis, no thoracic compensation, the patient retroverts their pelvis and their SVA looks normal. But because of the pelvic retroversion, this is what we call a false type 2 curve. And we have to be careful about creating these types of curves iatrogenically. They're quite common to do this. But this is the first stage of the degeneration. Once a patient can no longer compensate with their paraspinal thoracic musculature and their pelvic retroversion, you start seeing the development of some thoracic hyperkyphosis. And now the SVA is elevated despite the fact that the patient is likely maximally retroverting their pelvis. Once that degenerative compensatory mechanism fails and you have further loss of lumbar lordosis, further development of thoracic kyphosis, no additional pelvic retroversion compensation, you see that global decompensation of the spine where everything is off. Flat lumbar spine, thoracic hyperkyphotic spine, and pelvic and high pelvic retroversion. I will say that one of the important things to note here in these high PI curves, type 3 and type 4 curves, is that people will develop thoracic hyperextension. So they'll have the loss of that lumbar lordosis, and before they develop this global thoracic hyperkyphosis, they'll often hyperextend their spine. And it'll make you feel, when you look at them, that you can stop at a low thoracic UIV to correct their deformity because you think this is a nice neutral flat segment. But the minute you give them the lordosis that you need, and hopefully you didn't give it to them in the upper lumbar arch, but say even if you give it to them in the lower lumbar arch, the minute you correct that lordosis, their spine is going to go back to where it wanted to be, and it's no longer going to look like that nice flat neutral segment that you initially saw on those standing scullies. Now you realize that you may have stopped in a kyphotic, near the apex segment of the spine, and you may be looking at impending PJK sooner than you expected. So, moving forward, anesthesia adjuncts, I use TXA. I try to keep the blood pressure as low as possible, permitting no other prohibitory factors, like cervical stenosis or some type of cardiopulmonary disease that prevents our anesthesia team from keeping their blood pressure, their MAPS below 70. But I find that significantly decreases blood loss, of course, perioperative antibiotics. And then in terms of surgical execution, it starts with positioning. I've gotten used to using these pro-axis beds. These are beds that you can either hyperflex or hyperextend the spine. In these cases, the hyperextension of the spine, not so much as pictured here prior to the start of the case, but really once you're ready to close the PSO, it's incredibly useful for a very slow, deliberate enclosure of that 3-column osteotomy. In terms of exposure and hemostasis, this is a trick that I picked up from Manish Gupta. He has these really nice curettes. They're called Lennox Mclaren curettes. I have no financial incentive disclosure or a tie at all to this company, but they make a very, very nice set of sharp cobs and curettes that are tremendously helpful to getting that scar off the dura. the grand majority of these patients that you're going to be seeing in fixing their flat iatrogenic deformities have been laminectomized, often, a large significant portion of their lumbar spine. And truthfully, at least for me, the challenge in these cases is not doing the bone cuts. It's actually getting to the point where you have gotten all that scar off the dura, skeletonize the dura, skeletonize where those exiting nerve roots are, so that you can start making those cuts. And a big part of that is having the correct instrumentation to do that safely and efficiently. Because if, you can either find yourself swimming in CSF and not being able to get through the case, or you're doing it so slow with the incorrect instruments that, you find that you spent the last 4 hours trying to peel scar off dura. So let's talk about once you get to that point where you've completely removed all the scar off the dura, important to not just know where the neural elements are, but you really need to take that scar off, because once you close that PSO, you don't want that indurated scar to buckle the thecal sac in when you close it and cause a cauda equina type syndrome. But once you get to this point where you have the thecal sac completely out and you have an idea of where those exiting nerve roots are, you can start making your cuts. So the first cuts that I make are cuts across the par. So let's say let's say we're going to do an L4 PSO here. So in this patient, I'd be interested in completely skeletonizing out the L3 nerve roots, the L4 nerve roots, and the traversing S1 nerve roots. So to do that, I take the ultrasonic bone scalpel. I'll make a cut horizontally across bilateral pars. That's the most efficient way that I've found to be able to find and thoroughly skeletonize that nerve root. Then usually this is a rigid mass, so it's not like you have these nice facets, but I'll get an idea of where the SAP would have articulated with the pedicle by looking at the top of the transverse process, and I'll make another horizontal cut here, and I'll repeat those cuts at that level below. And once the cuts are made, they don't always perfectly release, but I'll take an osteotomy, a 1/4 inch or a 1/2 inch osteotome, and just propagate and crack that cut that I make with the ultrasonic bone scalpel instrument, and then turn it 90 degrees, and you'll find that bone mass turns out and releases quite nicely and efficiently. Not only does it help you get through this efficiently, but B, you get to keep all that bone rather than drilling it away. So once you've done that, then I'll make my cuts across the TPs vertically. By this point, I will have isolated and skeletonized those nerve roots out to where they contact the TP to protect the nerve roots from when I'm making these cuts across the TP. And then I can push those nerve roots up or down to do my lateral extracavitary dissection of the vertebral body to plan my 3-column osteotomy. And, by that point, you'll have the pedicle skeletonized. I like to take a curved osteotome from lateral to medial and basically amputate the pedicle at its base. Again, trying to keep as much bone as I can. I avoid drilling as much as I can just to keep that bone. It's my autograft. But by the time you've removed the pedicles and all the facets, again, what you want to see, nice healthy thecal sac, and you want to have all those nerve roots completely skeletonized and free. You don't want any remaining pars over your rostral nerve root, because when that PSO closes, that pars, that little ledge that you left on when the spine was really flat, when it gets lordotic, it's gonna tug right on that nerve root and give that patient that dreaded post-PSO radiculopathy. So I want every nerve root completely free past the TPs, so that I know that there is no chance of those nerve roots getting dinged or congested when I close the PSO. And then at this point, once you've gotten there, proceed very slowly with a combination of a Penfield 4, a Woodson, then a downgoing curette, and then eventually that kind of long tamp-like instrument to know that you have the ventral thecal sac completely dissected out from that dorsal vertebral body wall, as you will eventually need to break that dorsal vertebral body wall to ultimately finish the PSO. I don't use temporary rods. I like pedicle racks. The reason I like them is because A, I can distract across them to open it up a bit more if I need to, but most importantly, B, I don't have to change one rod out for another if I want to go working from one side to the other as I make my way across the osteotomies. Now, this is something that I learned from Mike Kelly, and really the ortho group who's taught me a lot of this work here, is the traditional PSO osteotomy that we see in the textbook is almost like a triangle or a wedge like this. But it's really actually quite difficult to make that exact perfect triangular cut. And what we often do is make horizontal cuts, even though we don't intend to. And what you find is that even though you created some lordosis, what you actually did is you shortened the spine, both the posterior, middle, and anterior column. And if you didn't, you may even open it. And so what you did is an opening osteotomy, and you may not have as good bone contact as you thought you did. And I feel that that's a big failure mechanism in these PSOs, because you don't get good bone-on-bone contact, and then there's very little to heal across. So what we do, and what I learned from these guys is, especially if you've got already fused disc spaces, is to make more of a wedge cut like this, so that you leave the almost like a little bit less than 1/3 of that anterior osseous column intact, where there's complete bone-on-bone contact still, and then you close across this, and that allows you to maintain bone-on-bone contact, for one, for better healing of your PSO, but two, it actually prevents this whole spine from shortening, and that mega foramen that you create for your nerve roots to come out is not quite as small, and those nerve roots are less prone to being congested, causing a postoperative neurological deficit. And then the last thing is, because you're maintaining that anterior column height and not shortening it, you actually can get much more degrees of correction out of a 1-column, 3-column or out of a single 1-level 3-column osteotomy. Now, in the event where that disc space above where your planned PSO is not fused, I like to put a T-lift cage, a banana cage, right at the very front to substitute for that loss of bone there in that disc space, so that I at least have bone, metal, and bone. So I'll put a T-lift cage there again, and I'll cantilever over that to be able to get that same effect. So here's a different patient that I have, where I did a CT scan after the surgery just to demonstrate that. So this was a patient who had a prior L4 to 1 very flat posterior lateral fusion with interbodies, 17 degrees of lumbar lordosis, and we got approximately I don't know, it's like almost 50 degrees of lumbar lordosis correction. Some of that came from the top, but the majority of it came from that L4 PSO extended with that T-lift cage at the front. And you can see that exact shape of that cut, where we leave that anterior column intact to bridge into that T-lift and to create a bony osseous bridge with that vertebral body above, and then you collapse across that to get the lordosis correction there. In terms of how I make my cuts, I will take the bone scalpel, and I will make, if it's fused here, if there's bone, if there's not a disc, I'll make a horizontal and then a vertical, what I call a rail guide cut, so that then I can take a large box osteotome with the neural elements protected, and it has only one place to go other than that cut. So you won't be able to complete the cut with the bone scalpel because the instrument is not deep enough, but it will allow your box osteotome to go down that rail guide that you made for it exactly in the direction that you want. And I do that bilaterally. I angle it medially and then straight down, and then I turn it 90 degrees, and then you'll see that you get a huge chunk of that pedicle out. In terms of the depth, when I do the lateral extracavitary dissection, I get an idea of how deep that vertebral body is, and I also measure it out. And I only want to go down about a little bit over 2/3 of that length. If I put a T-lift cage in there, because it's an extended PSO, then I will basically take that cut down to where the dorsal aspect of that T-lift cage is, just so I leave enough bone bridging that T-lift cage to the vertebral body above and below the PSO. Once you're finished with that, and you already did that dissection ventral to the thecal sac to get that dorsal vertebral bony wall freed up, so that you can safely take down this downgoing TAMP and break through that. You want to have that dorsal vertebral body wall be as thin as possible, so that you can do this maneuver as gently, as controlled, and safely as possible to avoid something as dreaded as a ventral durotomy. And then I close the PSO. Once again, I use that pro-axis table to close the PSO. I will say, though, this has been a learning experience. One of the first times that I used this table in this case, I found that the table was way more powerful than I expected. And I brought this patient who originally had 45 degrees to 95 degrees. And, I basically freaked out. I thought that I had given them, an irrevocable neurological deficit by buckling their spine so much. And I immediately took out the lordosis, took a couple more x-rays until I was happy with it. And, thank God the patient woke up neurologically intact. But, I'm a lot more careful, and I do it a lot more gradual now. But the point here is that this table is quite powerful, and you have to appreciate how powerful it is, because it can also be dangerous. And so this is how that patient ultimately ended up. And then in terms of bending the rods, I essentially try to bend them into one of these 4 type of configurations. Again, trying to recreate what I think that patient's ideal pre-pathologic Roosterly curve type would have been prior to them undergoing, the severe degeneration of their spine and malalignment and that, poor iatrogenic flat back deformity that they underwent. And then after that, I graft the spine. I usually use all that nice autograft that I got to keep by not drilling anything away, by essentially using only osteotomes and the ultrasonic bone cutting instrument. I don't use any fancy allografts. I essentially just use bone chips as a little bit of filler and conduit for my autograft. And I'll use 2 large BMPs unless there's some type of contraindication in that patient. And then here we can see how what the surgical execution of this look like. And we can put, here's a coronal image, and then we can put some numbers on it. I tried to dial in exactly the lordosis that preoperative program I used told me I needed to get this patient to stand with their head above their pelvis. Here, the patient's actually retroverting their pelvis a bit more than preoperatively. It used to be 8 degrees, and now it's 6 degrees. So her SVA looks slightly negative at 1 centimeter. But the T1 pelvic angle is essentially 1 degree. So her thoracic spine is essentially completely above her femoral heads. And then in terms of postoperative care, you have to be very diligent about the resuscitation of these patients, careful neurological exams. I like to get a neurological exam immediately after they wake up to know that I don't have to take some of the correction out of the patient, but then, follow them very closely for the first few days out of surgery, because they can tank. So, I'll quickly go through one of these, one more case here before I finish, just to kind of drive home the points. In this case, this was a 49-year-old female. It's very similar presentation to the last patient, presented with a prior history of multiple failed lumbar fusions. As you can see on that x-ray off to the left, she has multiple broken rods. Despite the fact that on the CT scan, it looks like there's bridging bone anywhere. She has a functional pseudoarthrosis at some point somewhere in her instrumentation, because she's breaking down completely. She's walker dependent. She's developed such severe proximal junctional kyphosis that she's unable to lay flat. She really has to lay on her side or sleeps in a recliner. She's unable to walk for 1 minute without a walker, and she feels that her hardware is popping out of her skin. Past medical history: asthma, gastric reflux, the surgeries that we just discussed, and she essentially, doesn't matter how much narcotics she takes, doesn't take her pain away at all. She is essentially narcotic addicted at this point. She's neurologically intact. And when you ask her about her expectations, she says, I just want my life back. And her husband says that she is about 1.5 feet shorter than the day they got married. And the ODI is very high. So once again, surgical indications, pretty crystal clear here. Somebody with a failed fusion, broken rods, broken instrumentation. If you look down here, she's retroverting her pelvis so much that her pelvic screws actually look like they're pointing up rather than down. She's actually quite young, and even though she looks way older than she is, she's still not so frail that I say, sorry, you can't get the surgery. I think she's still young enough and robust enough, despite looking much older than she actually is, to tolerate a surgery like this. And in multiple visits that we had prior to undergoing this surgery, she was accompanied by her husband and her children, and I felt that she had enough social history and support to undergo something like this. One thing is that when I counsel these patients, I tell them that these surgeries have a very high, near 90% combined minor and major complication rate. And they go, well, what does that mean? Say if you consider a blood transfusion, pressure ulcer, extended hospital stay, any little thing, a DVT, a complication, then you're likely going to get one or some of these things. It's not going to be, a completely rosy hospital course. But what I tell them is, I expect that something is going to deviate their care, and that, we'll be along with them the whole time and get them through it. And if you really manage their expectations like that ahead of time, they're going to be on your side, helping you get them through such a dramatic surgery, rather than not trusting you and maybe fighting you as you try to get them through this episode of their care. So looking at her imaging, she has about 45 degrees of proximal junctional kyphosis. T1 pelvic angle is 58 degrees. It's quite severe. SVA, 20 centimeters. She has 15 degrees of lumbar lordosis for a quite high pelvic incidence of 67 degrees. And as you can see, this patient is able to elevate her pelvic tilt much more than that last patient. She has a pelvic tilt of 46 degrees, which would be mathematically impossible for that last patient we saw, who only had a PI of 39 degrees. And then, thinking about that surgical plan, I go back, plan my cuts and my correction at different places. I say if I get, maybe 25, 30 degrees of closure across that PJK, just with positioning and posterior column osteotomies, as well as, a Schurman's kyphosis type of correction maneuver there. I maybe take that 45 degrees to 9 degrees. And then if I close that PSO approximately 40 to 45 degrees and give her approximately, 60 degrees to 65 degrees of lordosis, I may be able to get this lady to a T1 pelvic angle of less than 20 degrees. Easier said than done, but this was the plan. This is what we went for. Again, we don't have to go through the anesthesia adjuncts of the surgical execution portion as we just did, but this is what we finished with. Didn't get quite down to 9 degrees at her proximal junctional kyphosis, but I took her from 45 degrees to 14 degrees there. I took her from 15 degrees of lumbar lordosis to 69 degrees of lumbar lordosis, and to a T1 pelvic angle of 21 degrees, not quite the 19 degrees that I was shooting for, but still, I think a very dramatic correction for how poorly standing she used to. And then, I think the picture speaks more than the measurements. You can see how she stands now. And, she's quite happy. She actually cried in clinic talking about how she hadn't felt this tall as she used to be in a very, very long time. And this last slide, one of my mentors and teachers, Dan Chuba, who, taught me a lot of this as well in surgery, he'd always say, more correction, more lordosis, you got to have more cowbell. All right, guys, that's all I have.
Hey, that was great. Thank you so much, Camilo. That was a really nice background and introduction, and some really, really nice pearls. Alex or Mike, do you guys have any comments?
Hey, Camilo, that was an incredible presentation. I caught the last 20 minutes or so of it. I'm curious, when you do your lumbar PSOs, are you placing spoons around the vertebral bodies, and how important do you feel that it is to take the lateral vertebral body wall down when you do your PSO?
I do not place spoons. I just put usually a Raytech down. I think that the spoons can be a little dangerous. If that spoon kicks out as you do the osteotomy, it's going to kick out into the thecal sac. So I don't use them. I don't find them to be that helpful. I find that just a Raytech is enough to protect that lateral extracavitary dissection. And then taking down the lateral vertebral body wall, I think, is critical. The PSO is not going to collapse as much as you think it will without taking down that lateral bony wall.
Yeah, Camilo, very impressive cases you're showing us. I have a question. Just do you use a special software for planning? I asked several weeks ago, what is the best software for osteotomies? Can you give us a recommendation when you've got a surgical plan? Can you achieve your goals Is the software helpful for you?
Yeah, so the software is very helpful. I don't use anything special. This is my hospital PACS has a package called an ortho package that has this built into it, but it's really nothing fancy. All it does is, it's called an osteotomy, but all it does is, the package tells you if you make a cut here and change the shape here, what the angles are going to look like. So you can do that with SurgeonMap and a whole other host of programs out there. But the really important thing there is that once those programs where you make the cut, then you can close the osteotomy and you'll find that the patient looks like they're going backwards now. But then you can actually tilt the lower part below the cut. And what that does is show you the new pelvic predicted tilt. And you can say, this is how much lordosis I need to get this patient to get a healthy pelvic tilt for what their pelvic incidence is, and for their T1 pelvic angle to be something that's within a healthy range. Again, not so much about PI plus or minus 10 degrees, because frankly, a lot of the time that's not going to get you where you need to be. Some people need a lot more lordosis than that. Some people need less lordosis than that. It's really making a patient individualized plan each time. And I find that these softwares, SurgeonMap will help you do it quite easily. But it's about what do you need for that specific patient for them to stand with their head above their pelvis without a pathologically elevated pelvic tilt and a good T1 pelvic angle. That's probably the way I could distill it the simplest. And the other pearl is I try to put in all my lordosis, from L4 to 1. If it's a very high pelvic incidence patient, then I'll dial some of that lordosis in at L3, because I know that their apex of the lordosis naturally should be around there.
Yeah, thank you very much. Camilo, may I ask you how many of these osteotomies, of these complex spine procedures, do you do a year?
I've started doing them a lot more. My first year as an attending, I think I only did like 2 or 3. My second year, I think I did about maybe 10 or 15. And then this year, I'm in my 3rd year now and only a few months into it, and I've been doing quite a bit. So just in a few months, I've done about 10.
Oh, it's very impressive and beautiful cases, beautiful results. Well done.
Thank you.
Yeah, thanks a lot, Camilo. That was absolutely great. Definitely these are complex cases, and they should really be done in specialized centers. And you guys are very lucky to have one of course, the best centers for that. So thanks so much for this. As everybody know, this will be on YouTube, and we will disseminate that link to everybody. A lot of people tend to view these videos after, and looking forward to having you again with us sometime. Camilo, thanks so much for doing this.
Thank you, Ali. Thank you, everybody, for having me. Please feel free to reach out to me if you have any questions. I'm always available to help.
Wonderful. Thanks to all the participants and the faculty and our guests. We'll see everybody again next week. Take care, everyone.